Hello, my name's Steve Lewis. I'm an oncologist from Bristol. I'm going to give you a short talk on the management of acute neurological deterioration in paediatric oncology patients. In short, these are the same as for all children, but there are occasional additional causes, and the relative frequency of these is somewhat different. I'd like to think of it in terms of patients who present with a newly diagnosed malignant disease, but also talk about the deterioration that you may see in patients who are on treatment. Similarly, we'll talk about the neurological deterioration associated with a primary brain injury, so really we're talking about patients with brain tumours, or patients who have encephalopathy, and also those who have a more systemic process, which might be, for example, a metabolic cause or toxicity or some other factor. So, thinking first about brain tumours, if you look at the features of brain tumours at presentation, it's not surprisingly that quite a lot of these are associated with neurological deficit. Really, you find neurological signs and symptoms in most patients. Some of them are a little bit more subtle, with, for example, dementia or psychiatric illness, but a lot of these are clearly likely to be associated with significant deficit in these patients. In patients who have solid tumours, then the neurological component to their presenting features is somewhat limited. It's usually pain or loss of function. So if you have infiltration of a nerve, for example, or you have a fracture in a bone, you'll get associated dysfunction. If you have a lesion which affects the spinal cord, then of course you may get cord impingement, and therefore you get loss of spinal cord function. And then you can get this rather strange paraneoplastic condition, which includes things like myopsoclonus in patients with neuroblastoma, and very rarely you get an encephalopathy associated with tumours such as germ cell tumours. And then finally, you can get metabolic and nutritional problems arising in patients who have especially widespread tumours, this being either because of the metabolic effects of the tumour itself or because of isolated deficiencies. And then finally, just to complete the full house, leukemia itself can present with CNS-related symptoms. These are usually in patients who have CNS involvement with leukemia, and so they tend to be things like headaches and fits, but patients who have leukemia on treatment may also go on to develop encephalopathic illnesses because of their treatment itself. The differential diagnosis of a patient with encephalopathy is the same in oncology as it is for all paediatric patients, but the relative likelihood of these diagnoses is somewhat different. There's a very nice review in Archived Diseases of Childhood from 2001 by Fenella Kirkham, which would be worth having a look at. I've used that as a loose basis for my classification here. So, if you look at metabolic causes of neurological problems, these are largely due to things like hypoglycemia, hyperglycemia, salt deficiency or excess, and uremia. So hypoglycemia is more common in oncology patients because many of these patients are significantly undernourished and they have a poor reserve of carbohydrate. There's a lot of circulating factors which cause cachexia, and patients often have poor nutritional intake. Hyperglycemia is common especially in patients who are on steroids, common for obvious reasons. Hyponatremia and hypernatremia are seen especially in patients who have brain tumours, who have pituitary dysfunction, and also a function of giving too much fluids or allowing them to become dehydrated. Likewise, uremia in patients who either have renal failure because of a consequence of their treatment or because they're underfilled. We use a lot of drugs in paediatric oncology. They all have a very narrow therapeutic index, and it's not surprising that some of the side effects we see are neurological. These are the ones that I think are most likely to be underlying problems. They include things like corticosteroids, which can cause a psychosis or a depression, sedative analgesia, which is commonly used especially in patients who have discomfort with bone pain, for example, opiates, benzodiazepines, phenothiazines, cannabinoids used as antiemetics all have central neurodepressive effects. And then lastly, the chemotherapy drugs we use often have specific encephalopathic or neurological side effects. And just looking at these, I'll spend more time talking about these in separate talks on individual drugs, but ifosfamide-related encephalopathy is not uncommon, especially in patients who are undernourished, have renal dysfunction, or large abdominal masses, or those who have brain tumours. Cyclosporin, not a chemotherapy drug in itself, but an immunosuppressive drug, well known to be associated with thrombotic thrombocytopenic purpura, and an underlying encephalopathic process may be seen. Asparaginase causes thromboembolic disease, so you may end up with strokes. Cytarabine causes a well-defined neurotoxicity, and methotrexate, which is used widely in leukemia and other diseases, is well described to be associated with an encephalopathic illness, sometimes associated with the reversible posterior leukoencephalopathy syndrome. And so all in all, these are quite a significant group of potential causes. Infection is an important factor not to miss, meningitis doesn't seem to be common except in patients who have undergone neurosurgical procedures. Encephalitis, of course, can happen in all patients. Neurosurgical complications include ventriculitis and shunt infection, and if a patient has undergone recent neurosurgery, then this really has to be high on your list of potential causes. The incidence of shunt infections falls away with time. It's still possible to get a shunt infection 6 months after a procedure, but the incidence is getting quite low by that time. But again, it's very important not to ignore this, and you should be discussing neurosurgical management in patients with encephalopathic illnesses anyway. Hemorrhage and thrombosis are important causes. A lot of our patients have low platelet counts, and if that's the case, then you're at risk of an intracranial hemorrhage. A patient who is encephalopathic and known to have low platelets, you should be thinking about giving platelets urgently. Diffuse intravascular coagulation can be a presenting feature of leukemias. Some widespread malignant diseases other than leukemia, and of course can be a feature of sepsis or dehydration. TTP, similarly, can be associated with various drugs that we give, including chemotherapy. And you can get hypoproduction of coagulation factors, either because the patient's malnourished or because they're not absorbing vitamins, or as a complication of L-asparaginase therapy. And indeed, as we've moved over in the UK from Erwinia asparaginase to E. coli asparaginase and to pegylated asparaginase, we found that this incidence has increased dramatically. Dehydration is a predisposing factor for thrombosis, as is sepsis. The tumour itself may be a cause of the neurological problem, and that's usually patients who have primary brain tumours, but of course you can have metastases and you can have paraneoplastic conditions as well. And post-neurosurgery complications are many and diverse. In the early stages after an operation, you have to think about acute events such as bleeding, infarcts and shunt dysfunction. One of the more important factors, which is relatively common, is this thing called the posterior fossa syndrome. The patient will normally show recovery after an operation, but then become progressively more withdrawn. Their interactivity with the outside world becomes progressively less, and it's sometimes necessary to exclude other reversible and treatable causes, before making this diagnosis. So, how should we manage a patient who has acute neurological deterioration? Well, essentially it's exactly as you learn in paediatric life support strategies. So you think about airway and breathing, you think about circulation, and you assess the level of disability. And I'm not going to talk very much about ABC, but I will talk a little bit about assessment of neurological state. The important things we need to think about are what is the level of consciousness, how do we quantify that. Posture is a helpful factor, and pupillary responses is also quite helpful. So assessment of level of consciousness comes in various ways, but the most popular one that we use is the Glasgow Coma Scale, and then a very abbreviated version of this is the so-called AVPU algorithm abbreviation. So this is the Glasgow Coma Scale, and it's worth just spending a few moments paying attention to this. Firstly, the original Glasgow Coma Score applied to older children, but it has been modified so that we can now apply this to younger children. And the components are eye-opening, verbal response, and motor response. And you can see that the maximum score you can get 4, 5 and 6 means that your GCS of 15 is the maximum that you can reach. A patient who has spontaneous eye opening, is orientated or is alert and bowling spontaneously, obeys commands or has normal spontaneous movements, has a GCS of 15. AVPU is a very useful rapid assessment tool. Patient who is alert or has response to voice is probably reasonably safe. If you have responsive to pain only or unresponsive, then your GCS is likely to be very significantly lower, and you need to think about ventilating this patient rather urgently. Let's move on now to specifically thinking about raised intracranial pressure, because it's an important part of the assessment of the causes of patients who have neurological deterioration, and one which in my experience is somewhat underestimated. So the symptoms of raised intracranial pressure we all know are things like headache, vomiting, lethargy, cranial nerve palsies, irritability, poor feeding, and to some extent confusion. The signs are reduced level of consciousness, an increase in blood pressure, a reduction in heart rate, sunsetting of the eyes, bulging fontanelle, distension of scalp veins. Eventually you may get papilledema, eventually you may get gasping respirations, and you may well get pupillary changes, and of course coma is the end result of that. This is an important thing to have in the back of your mind when you're thinking about the way in which someone's brain is working, and it's just the concept of a cerebral perfusion pressure. And the cerebral perfusion pressure is the pressure which is actually driving blood through the brain. So it's your mean arterial pressure minus your intracranial pressure. So if your mean arterial pressure is 100 and your intracranial pressure is 20 or 30, then you're going to end up with a cerebral perfusion pressure of 70 to 80 millimeters of mercury, which is normally seen. But if your intracranial pressure starts to rise, your cerebral perfusion pressure will fall, and therefore the speed of flow of blood through the skull falls too.